This PowerPoint will cover the condition rheumatoid arthritis, also commonly abbreviated as RA. The objectives are to have an understanding of the pathophysiology and risk factors of RA, knowing the signs and symptoms and how a patient would typically present, as well as learning the labs, imaging, and treatment of RA. General information. RA is a chronic autoimmune disease that affects the synovial capsule surrounding joints. The body recognizes its own proteins and cells as foreign and causes an immune cascade and inflammation around the synovium. This causes pain, inflammation, and limitations with that joint that affect the range of motion and strength. RA affects women 2 to 3 times more than men, usually in their 50s or 60s. RA has a large genetic risk factor. This is caused by the HLA-DRB1 gene. This gene is part of a class of genes known as human leukocyte antigens. These genes help distinguish between the body's own proteins and foreign ones. A mutation in this gene can cause the body to attack its own proteins. A person with this gene is 5 times more likely to develop RA. This gene also plays a role in other diseases such as multiple sclerosis. The genetic component plays a large role, but otherwise, smoking is the strongest known environmental risk factor. Other risk factors include being a woman, age, and exposure to environmental toxins. Signs and symptoms. Patients will present with pain, swelling, and stiffness of symmetrical joints. This is most commonly in both hands or wrists. The pain and stiffness is worse in the morning and improves with activity and movement. The MCP and PIP joints are most commonly affected. That's the metacarpophalangeal and proximal interphalangeal joints. The pain is ongoing, lasting longer than 6 weeks. In late disease, the heart, lungs, and eyes can be affected, but this is in very severe cases. This image here shows how a patient's hand may look when they present with rheumatoid arthritis. Note the swelling to the MCP joints. Labs and imaging. Autoimmune markers like rheumatoid factor and antibodies to cyclic citrullonated peptides are likely to be positive in RA but don't have to be. These labs are present in about 80% of patients. The anti-CCP antibody has a 97% specificity for RA, and having this antibody defines a patient as seropositive for RA. Other inflammatory markers such as ESR and CRP will be elevated. Other tests you might want to consider ordering would be an ANA and an ANCA to help rule out lupus, vasculitis, or other autoimmune diseases. Imaging can help make the diagnosis. X-ray findings include soft tissue swelling, joint effusions, and symmetrically narrowed joint spaces with ongoing disease. In more severe cases, patients can have that boutonniere deformity or ulnar deviation of the wrist. In this image here, you can see the erosion of the bone in the 2nd, 3rd, and 4th digits, as well as the wrist, as well as narrowed joint spacing and tissue swelling around those sites. Making a diagnosis. Differentials of RA include osteoarthritis, fibromyalgia, reactive arthritis, lupus, and vasculitis. There are several factors that can help make the diagnosis of RA. This includes symmetrical arthritis in small joints, especially in the hands or wrist, evidence of soft tissue or bone and cartilage damage on X-ray, positive rheumatoid factor or anti-CCP antibodies, as well as symptoms lasting over 6 weeks. The American College of Rheumatology has set forth guidelines for diagnosis and treatment as well. Early diagnosis and treatment is extremely important and will prevent progression of joint damage in patients. Treatment. Disease-modifying antirheumatic drugs, also known as DMARDs, should be initiated as soon as possible after diagnosis. DMARD of choice is methotrexate. Methotrexate is used first line as monotherapy due to its effectiveness in achieving disease remission, lower cost, and manageable adverse effects. Other examples of DMARDs include sulfasalazine and hydroxychloroquine, but the American College of Rheumatology recommends methotrexate. NSAIDs and glucocorticoids can be used as adjuncts for pain and inflammation control as well. Biologics would be your next step after DMARDs. You can follow the guidelines set forth by the ACR to help with treatment. And this image here just shows an example of a methotrexate dose package that your patient might be put on. And here are my references. Thank you for listening.